What is up, guys and girls? It's Stephanie again from the driving safety medic. Today's another awesome day here by us. It's raining just hard enough to actually not be wet and cold and all of that crap. But it's raining. It's lovely, man. It's lovely. You can see a bit on my little sunroof, the droplets forming there. So, as always, I'm on the road, and I'm doing this video for you guys on my little cell phone thing, my Kwaki. So here we go. In my one previous video, I told you guys about the protocol ABC all the way to J. And I'm still tired, but it is what it is. And in the video I mentioned to you guys that I'm going to discuss the CPR with you guys pertaining to the look, listen and feel. Now, CPR is a continuously evolving protocol. When I was in primary school, I can't remember the exact dates and stuff, but I vaguely remember primary school time period. CPR was taught with, if I remember correctly, 1 breath, 5 compressions that you did CPR. I think about when I was in high school somewhere, CPR changed to 2 breaths, 15 compressions. Then at some point CPR then changed to 2 breaths, 30 compressions. Okay, and this is important because it just shows that the CPR is subject to research and extensive practice to ensure that it is as effective as possible. I'm sure sometime in the future, once a new finding has been made during the research, it'll probably change again. Okay, as what it did with the COVID, because the COVID forced us to, not us, forced the American Heart Association to re-look at the protocol, because you have to look at the safety element and the risk factors for that person actually giving the CPR. And I'm going to discuss that with you guys now. So as I said to you guys, when you look at when you look at the protocol, you're going to go A, B, C, airway, breathing, circulation. Alright? But please don't let the CPR confuse you, because CPR goes C, A, B. Protocol ABC, CPR CAB. It's a bit backwards. I mean, this is like not what they taught me in grade 1. I think I need to go and get my grade 1, sorry, preschool. I think I need to go and get my cash back from that preschool that I was in, pre-primary school that I was in. So CAB stands for compressions, airway, breathing. Firstly compressions, then airway, then breathing. Now this is a bit of a technical element, because if you find your patient unconscious, alright, you don't know what the cause is of the cardiac arrest. Whether it be a heart attack, whether it be poisoning, whether it be, I don't know, there's like a lot of elements that can cause cardiac arrest. One of the elements could be choking. I mean, if you've got complete airway obstruction, there's no air moving in, moving out. What that results in is, because there's no air moving into the lungs, it means there's no oxygen going into the lungs. If there's no oxygen going into the lungs, there's no oxygen going into the blood. If there's no oxygen going into the blood, what we discussed in the previous video, after 4 to 6 minutes, you're going to start seeing tissue death. Okay. So if there's no oxygen going into the blood, after 4 minutes, you're going to start seeing tissue death. Eventually, you're going to have tissue death in the brain and the heart, and it's just going to go south, and the person's heart's going to stop. Alright. So if we were to apply breathing first, the risk here is, as you're blowing into the patient's mouth, if there is a foreign object stuck in the windpipe, aka trachea, you might blow that object even deeper, possibly. I'm not saying it's definitely, but possibly. So that is a risk that we want to avoid. By performing compressions first, you are putting a slight bit of pressure on the lungs, which then whatever residual air was in the lungs from before the dude choked or the lady choked would be pressurized and possibly, maybe, hopefully dislodge and move that object up into the mouth. Okay. Then after we've now done our 30 compressions, then we go to A, airway. We're going to look in the patient's mouth to see if there is any foreign objects. If there is, we can do the finger sweep that we discussed in the previous video. If there is no object, we can then proceed to do B, breaths. CAB, compressions, airway, breaths. And it's 2 breaths. Compressions, 30 compressions, as I mentioned in sort of towards the start of this video. Now, I want to quickly go back to your protocol ABC, airway, breathing, circulation. Pre-COVID, it was very nice, quick, easy. Open the mouth, finger sweep, head tilt, chin lift, look, listen and feel for breathing for 10 seconds, and then check for circulation using it on your carotid artery. Okay. And I'm in traffic again. Yay! I love driving, but I just don't like traffic. Now, the problem with B, breathing, and with the whole look, listen and feel principle, if you consider COVID, if you put your face right next to the patient's mouth and the dude or lady, should you say dude or chick? Dude, chick, dude, is breathing and they do have COVID, you are at risk of getting infected. So what the American Heart Association, and then by default here in South Africa, the Resuscitation Council of South Africa, which is sort of the governing body for CPR. And this is another interesting fact. The American Heart Association and the South African Resuscitation Council is sort of the governing body for our CPR protocols. Alright. This is where an interesting fact comes in, if I can get my train of thought together. This is the only sort of real governing body. We don't have a real tangible governing body for spinal injuries. nor do we have a governing body for treatment of lacerations. We've got the HPCSA, Health Professions Council of South Africa, that does provide us with guidelines based upon international best practice. But it's, especially if you look at like the first aid related things, it's not as comprehensive for the minor procedures as what the Resource Council stuff is. To an extent that even if you can look at spinal, a lot of paramedics now is no longer using the C-collar, the neck brace. But if you can look at the clinical practice guidelines from the Health Professions Council, nowhere does it state that you can't use. It vaguely states that the cervical collar, the neck brace, there is no sufficient evidence. I'm paraphrasing, I can't remember the exact wording. There's no sufficient evidence that the use of the collar is beneficial or detrimental for that fact. But we've just done away with it because the interpretation on the clinical practice guidelines varies. Anyway, so back to the look, listen and feel. When we are during COVID, the American Heart Association and the South African Research Council brought out a protocol for CPR, and it goes sort of like this. So you approach the patient and you are left open with quite a few choices. First is, if you know the patient and you know that they have not displayed any signs of the coronavirus, okay, and you know that they haven't done any high risk traveling to sort of a SARS COV-2 hotspot, then you can proceed if you choose. If the person has not, if you don't know the person, or you are unsure about their travel arrangements or travel history, and you are unsure whether they have displayed any signs, you don't have to give breathing. It's actually recommended that you don't do the breaths. You only do the chest compressions. Now, every time you're doing the chest compressions, as I said to you earlier, you're putting a tiny bit of pressure on the lungs, which will force air out. So that still puts you on the risk. If you are doing CPR on a patient that possibly, maybe, could be infected with the coronavirus, whatever strain it may be, that particles can still come up in the air and you can still get into contact with the virus. So what the recommendation here is that you are actually needing to put either a mask over the patient, obviously mouth and nose, or a cloth. Please don't put a damp cloth. We are not in the business of waterboarding anybody. We are in the business of saving people. So just put a cloth over the patient's mouth, preferably a mixed fiber, mixed material, just put a cloth over the patient's mouth so that those particles doesn't then come up and into contact with you. So that's actually doing CPR. If we go back to the breathing, we are then not going to do the look, listen and feel method. What we are going to do in this instance is we're going to assess the patient visually for breathing. You might, I don't know, put your eyes over the stomach, look for any chest movements. You might stare at the patient from the side, look for any chest movements. If you want to, you can put your hand over the patient's mouth and nose, as long as you've got sanitizer or a glove or something that you can afterwards then use to reduce your risk of getting infected yourself. Alright, so just to now sort of synchronize what I said, we're still going to do a airway without going close to the mouth. Check the mouth visually, do a finger sweep, sanitize afterwards. Do not touch your nose, mouth, hands, face. No, you're touching your hands anyway because your hands are on your body. Hands is what you use to touch. Be breathing, visually inspect the patient without doing the look, listen and feel. If, again, all those criteria, do you know the patient, don't you know the patient, signs and symptoms of corona, etc., as I discussed just now. See circulation. You are quite safe to actually check pulse for the carotid. If you've got a stethoscope, you can check for heartbeat, osculate the chest if you want to. That's actually quite a lucky idea. D, does the patient bleed? E, effect CPR. Again, as I said earlier, depending on those couple of questions you've got to ask yourself, make the decision. Are you doing hands and breathing CPR, or are you doing hands only CPR? Hands only CPR is one of the elements in the basic life support sort of syllabus. Hands only CPR is a fantastic tool for the layman that hasn't received all of this bunch of training. And now with the CPR, with the traditional, you're going to do 30 compressions, 2 breaths. That sequence 32 should take you in the vicinity of somewhere give or take 2 minutes, if you're doing it correctly. When we're doing a hands only CPR, you're going to more look at the elements of compressions for 2 minutes. You've got to either put a timer on or guess 2 minutes. You can probably do the maths. If you're like a smart T-pants, you can comment in here, because our compressions is a rate of 100 compressions per minute. Hey, I can actually do that. 100 per minute. If I need to do it for 2 minutes, that makes it 200 compressions if I'm doing it at the correct rate. Hey, I'm a smarty pants. Don't comment. And as you can see in my background, I'm back in traffic. So do your 200 compressions for the 2 minutes, and then you can check your circulation, check your pulse again. Alright, so guys, that's just quick what I wanted to discuss from our previous video is the COVID element. COVID isn't as prominent anymore. I know there was just a new strain that was now found again, but I think we sort of, touch wood, over the camel's back, over the donkey's back, we're over something's back with this whole corona thing. So what I want to say to you guys is, if you are in the situation where you need to do CPR, barrier devices, your mouthpiece, your pocket mask, those aren't effective to filter. The little filters they've got in them is not effective to filter the coronavirus. So please use your common sense, your logic. in making a decision whether you're doing hands only or hands and breathing. All right, as I said to you guys, first HS history, second HS hazard, and I said to you guys with hazard that your safety is extremely important. All right, so that's it from me for this video, guys. Have a smashing day. Further, like, share and subscribe, smash the bell icon. If you like the content, if you want other content, please chuck it into the comments. If you want a content on how to, I don't know, recycle or something, just put it in the comments. I can do a video on that. And yeah, let's have a good one, and I'll check you guys in the next video. Alright.